Hi everyone, I'm Kimberly and this is my presentation on metastatic melanoma and immunotherapy. To understand what metastatic melanoma is, we first need to understand what is melanoma. Melanoma is one of the most aggressive and deadly skin cancers. It is also one of the most common, with cases of it estimated to double every 10 to 20 years. So metastatic melanoma is when the melanoma is in its advanced invasive fourth stage. In the left pic here, you can see different kinds of melanomas, and this right pic is specifically a metastatic melanoma. So metastatic melanoma is very deadly because it cannot be removed or is very hard to control and treat because it has already spread past the original skin cancer site at this point, or it has metastasized, aka grown and spread to other body sites like the internal organs. Cancer cells can even break away from the original tumor and spread throughout the body. Even though we currently cannot, quote, cure metastatic melanoma, treatments are offered to improve the patient's life quality and expectancy, either by killing some of the cancer cells and shrinking the overall size, or slowing its growth. These typically mean going through drug or radiation treatment, like chemotherapy, or removal by surgery. There has also been recent research into the immunotherapy treatment of anti-PD-1 monoclonal antibodies in combination with pretreatments to treat metastatic melanoma. So far, it has shown great promise in increasing patients' life expectancy and lowering the very high mortality rate of melanoma, and has become a standard treatment actually in many medical institutions. To keep it short and simple, I'm going to abbreviate monoclonal antibodies to MABs or MABs. So MABs are primary antibodies in targeting and eliminating cancer cells, and in order to carry out this function, they rely on its variable regions to bind the antibody to the target antigen of the cancer cell. So in the case of most anti-PD-1 MABs, the variable regions will include a chain called an IgG4S22-8P. This is what supports the MAB's primary function. And to help explain the MAB's role, during a cancer's development, a human's IgG4 has a strong bond, or a high affinity, with the cancer molecule, the FeGRI molecule. This bonding is what contributes to the persistence of the cancer cell survival. This is where the anti-PD-1 MABs step in. These antibodies have a L234A and an L235A or LALA mutation that prevents the binding of the IgG4 molecule and the FeGRI molecule. Preventing this bond will, in theory, provide support in the treatment therapy process. However, a concern is that the IgG1 antibody prologlimab may have a mutation that prevents the LALA mutation to the FCGR cancer receptors from happening to serve the primary goal of eliminating the cancer cells. To clarify, a prologlimab is a part of the anti-PD-1 MABs that has the part of the LALA mutation, which essentially discourages the Fc of the cancer receptors from its cancer activity. A research study was actually done to address this concern. Basically, they had metastatic melanoma patients take 2 dose regimens of the monotherapy. What they found was that the prologlimab did confirm the patients of a poor prognosis, aka low chance of recovery. And they concluded that the safety and efficacy of the anti-PD-1 MABs are likely significant in treating melanoma. However, Of course, since this is new, more research is ongoing and needed regarding this concern, other concerns, and this topic overall. And as you can see here, here's a cancer cell, the monoclonal antibody, the antigen, and this is a monoclonal antibody in action. Now we want the best chances and outcome possible in treating a melanoma patient. So, before, during, and even after the anti-PD-1 MABS therapy treatment, additional treatments are done to help determine and essentially, quote, customize a metastatic melanoma patient's treatment therapy course. Factors like how much of a dose, how often the dose is administered, and more. There are various pretreatment options and actions taken relating to the anti-PD-1 therapy in melanoma. In this presentation, I will be discussing contrast-enhanced computed tomography, identification through biomarkers, and determining the length of the anti-PD-1 treatment. So what is contrast enhancement computed tomography, or CT? It is an added treatment plan that happens before, during, and after the overall metastatic melanoma treatment of the patient. It detects and does a texture analysis of the cancer tumor to keep track of its evolution and development and response to the treatment by producing very detailed, clear images of the tumor. Its purpose is by having a clear image of the cancer, it allows doctors to gain a better understanding of the situation and the tumor to help decide first if the patient is a good candidate for the MABS therapy treatment, as not everyone may respond well to the immune and checkpoint inhibitors involved, but also potential approaches and plans towards treating that individual cancer and predicting the outcome depending on the different treatment plans. So during and post-cancer treatment, patients can actually react to the therapy differently and at different points in their treatment plan. This includes developing atypical patterns of the treatment due to a change in the cancer. Again, the CT helps to track the cancer's progression and reaction to the treatment. So knowing where the cancer is at certain points of the treatment, professionals can predict, adapt, and make appropriate changes in the overall treatment plan along the way to get the best possible outcome. And as you can see here, these are examples of a patient with metastatic melanoma, and these are their CTs. Then we have biomarkers. As opposed to contrast-enhanced computed tomography (CT), biomarkers are more so used pre-metastatic melanoma treatment to predict possible outcomes of this specific treatment. These indirect biomarkers are to detect cancerous tumor growth and help identify good candidates for the anti-PD-1 MABS therapy treatment. So why have biomarkers if we have CT? Like I said, it is to identify patients who will likely be good candidates for the treatment, because although it can significantly improve the life quality of the metastatic melanoma patients, 50 to 60% of these patients, usually those carrying advanced, fast-growing tumors, have skin cancer cells that are resistant to the immune checkpoint inhibitor of the antibodies. So knowing whether or not a patient is a good candidate for the therapy treatment early on within the diagnosis, experts can better utilize the patient's precious time, not to mention their own, in deciding what actions should be taken in the patient's individual case. New methods have been developed to replace the existing biomarkers methods in identifying good candidates. A recent one is considered to be more realistic. As it helps to come up with like a general pre-treatment plan based on the tumor and its growth rate. In this method, the idea is the high metastatic growth rate correlating with the low metastatic melanoma survival and its response rate to the anti-PD-1 mAbs treatment. This method essentially utilizes tumor growth kinetics with an indirect serum biomarker called the LDH. The LDH biomarker focuses on a tumor's effect on the body and the tumor's cell turnover to measure and predict that cancer patient survival rate. Obviously, duration of the treatment is a very important factor. It is based on the patient's progress and needs in addressing their metastatic disease. And like many other treatments, there are side effects on the anti-PD-1 mAbs treatment, no matter its success rate in effectively lowering mortality rate of the metastatic melanoma. These side effects can range anywhere from mild to severe. A common side effect is often referred to as late-onset toxicity, and typically applies to patients who have gone under the therapy treatment for 12 months. Late-onset toxicity is basically having a toxic level of a drug in your body that can lead to serious problems down the road, sometimes even death. It depends on the drug used, the amount, and the health and age of the patient. Some drugs can be more toxic than others at the same dosage, and younger patients tend to have a higher toxicity mean compared to older patients. In the case of the mAbs treatment, it raises the question if the treatment needs to be administered in a strict, standard, complete chronological order across all metastatic melanoma patients. Based on long-term data, where these patients were not given a complete chronological treatment, it suggested that they can still achieve a higher life expectancy when given a more sustained and sometimes even discontinued treatment. Now, doctors are starting to prioritize the time within the treatment with up to 2 years. Not only is this approach more convenient, less expensive, and less mentally, emotionally, physically demanding on patients and the doctors, but it redefines what is considered optimal medical treatment. Consistency and intensity remain important, but we also need to consider time as an important factor. And here are some tips to preventing melanoma. As some of you may already know, a sunscreen is a great step to preventing cancers, skin cancers. And you have to wear them daily and properly. This means applying a liberal amount of sunscreen to your face, neck, ears, lips, hands, scalp, hair, and really any other skin exposed to the sun. And reapplying at least every 2 hours and every 80 minutes after sweating or being in the water. Extra steps you can take are limiting your sun exposure when the UV rays are at their most intense, and this is when the sun is at its highest point in the sky. And you can identify this when your shadow is shorter than your actual height. This is usually from 10 a.m. to 4 p.m. or 10 a.m. to 2 p.m. depending on the weather, the season, and other factors. But almost always, it is at noon especially. You should also wear UPF clothing, or at the very least cover up with long sleeves or other things such as hats, sunglasses, visors, rash guards, gloves, and more. Also, avoid tanning, including tanning beds, because a tanner's skin, excluding topically applied tanners like spray tans or lotions, is usually a sign of damaged skin cells from the UV radiation and our skin producing the pigment melanin to prevent more injury to the skin. Melanin is actually what makes the skin appear tanner. And tanning from UV radiation damages your genetic DNA that can lead to mutations that may result in the development of skin cancer. In the case of tanning beds, one is exposed to UV radiation at very high amounts, and consumers typically do multiple tanning sessions. Also, skin cancer is cumulative, and So that means that you can develop skin cancer with over time exposure of UV rays. It doesn't have to be the like a one-time exposure to UV rays and within like one beach trip or something like that. It's cumulative over time. And then there's also skin exams as an extra precaution that we should actually be doing annually, which should be done by the board certified dermatologist, where they basically look at every skin crevice, every single patch on your skin to check for any moles, anything involving, anything that they think should be checked out further. And if you cannot see a dermatologist or would like an alternative for these skin exams, a good one is to do self-skin exams once a month, which is basically the same thing, except you're the one looking at your skin, and preferably with the help of someone else to really look at every single crevice of your skin in areas that may be hard for you to look at yourself. And some final messages is that I just wanted to make the disclaimer that these are general guidelines and tips to preventing skin cancers. But of course, always, always talk to your doctor for any health concerns and questions. And finally, be sun smart. Sun is our friend in the sense that it plays a vital role in our physical, mental, and psychological health, growing food, in our nature, and overall speaking, biology. We should not fear the sun, but instead be smart about our exposure to the sun and its UV radiations to help prevent skin and health problems. And these are my citations, and thank you.